Good evening to all of you all. On behalf of Sri Lanka College of Specialist Family Physicians, we are conducting series of academic programs in order to provide you the guideline management and as well as the provide the practical knowledge on how to take correct history from patient and as well as that is the evaluation of patient at primary care settings that includes the correct taking of correct history while excluding red flag symptoms and as well as the consider the patient's psychosocial aspect during the history taking and as well as the examination very much focused system examination and then come to the possible clinical diagnosis which needs to be confirmed by minimum relevant the cost-effective investigations to manage patient or to identify the patient's red flag, the confirm the red flag disease in order to the hand over the patient for the secondary care or tertiary care, either referral or the admission, or for any other services which we need to, that is coordinated care. So this is behind having that the agenda behind in order to provide you the best the evidence based patient management at primary care setting in par with other international standards, other countries which practices the best evidence-based the primary care with the very well established primary care system in other countries. So since specialist family physicians have been trained to provide the very much safe first contact care, we are being allocated our trainees to provide that the competent training for them to get the board certification to provide best the patient-centered care in Sri Lanka. So because of that, having that the purpose, we are training our registrars. The currently we are the registrars who are with us for their training. So now I would like to introduce our college, Sri Lanka College of Specialist Family Physician, as the president of our college, Dr. Malkanthi Galhina. I'm attached to BH Panadura and I have the family medicine clinic at that place. And as well as there are so many consultants in the country now, although they are in limited number, our focus is through this college to provide not only the members, you can take the membership to our college as well, but not only the members, but as well as to other non-members to provide the best, the patient-centered knowledge for you all to satisfy your patients and as well as to give the protection for their illnesses. So thank you very much for joining tonight. Sorry that I couldn't, send this link before as we were practicing before because of my busy schedules. I apologize for that, but hereafter it won't happen. We will send you the in advance link so that you all can join and expand your knowledge. So thank you so much for joining, as well as special thanks to our college, the specially registrars, the registrar who is going to do that, Dr. Chulika Wijethilake, as well as the other team members of our college, the registrars, and especially to make these flyers and all, the senior registrar, Dr. Sinduppa Seneviratna, Dr. Prabhat Narakara, and other team, Dr. Kasunjit, and all other team are highly welcome. And I would like to give my sincere appreciation for your kind contribution. So, Chulika, it's over to you now, so you can start.
Thank you, madam. I'm Dr. Chulika Wijethilake.
So you don't know how much you was telling. You didn't even take that and see. No, don't. Because there is one, the board
So,
is
please switch off your, mute your the speakers, because it's really disturbing to this program. Sorry about that. Please, the keep the phones muted. Okay. Right. Chulika, now you can start.
Thank you very much, madam. Good evening. I'm Dr. Chulika Wijethilake, currently attached to primary care clinic, base hospital, Panagura, under the guidance of Dr. Malkanthi Galhena. Today, I am going to present you a case scenario on regarding evaluation of patient with chest pain. Case scenario, 62 years old Mrs. Indrani came with moderate severe central chest pain from morning. She had same type of on and off mild to moderate pain for 1 week. On elaborating her pain, she had burning type of pain, episodic attacks lasting for 5 minutes, no radiation, no sweating, but she had nausea, no vomiting, no palpitations, no fainting attacks, pain not triggered by exercise or breathing. Increased after meals and on lying down, no difficulty in swallowing or painful swallowing. On system inquiry, her appetite was normal. She had noticed recent weighing. She had constipation, no hematemesis or melena. She gives a history of occasional night cough, but no other respiratory symptoms or fever. No trauma to chest, no recent travel history, no calf pain on walking. Her mood was normal except for fear about chest pain. Her past medical history. She was hypothyroid. She was on treatment for hypothyroidism for 10 years on thyroxine 50 microgram per day. She's on treatment for dyslipidemia for 3 years on atorvastatin 10 milligram. She was on treatment for knee joint pain with NSAID for last 4 months. No history of chest pain, no history of gastric ulcer or surgery involving the bowel. Family history. No premature heart-related deaths or other significant illnesses. She's a mother of 3 children. Her husband is a retired and her children are employed. She does minimal household activities and exercise. Considering her diet, she consumes a lot of spicy and oily foods, bakery products such as bread, bun, and other pastries. She consumes less fruits and vegetables, no smoking or alcohol. She consumes frequent tea and coffee. On examination, general examination, BMI was 32, no dyspnea, not pale, no xanthelasma, no lymphadenopathy, thyroid gland not enlarged, normal consistency, no ankle edema, no calf tenderness. Her ankle jerk was prolonged. Sorry for the mistake. On examination of the cardiovascular system, pulse rate 68 per minute regular, blood pressure 110 by 75 millimeters mercury, apex beat normal, not displaced, heart sounds normal, no murmur, no carotid bruit. Examination of the respiratory system, trachea central, no chest wall tenderness, respiratory rate 18 per minute, lungs, vesicular breathing, no added sounds. Abdomen, Tenderness over the epigastrium was noted. No hepatospleen with no free fluids. Considering the history and the information so far we gathered, what are the possible DDs from the audience? Any possibilities?
Gastroesophageal reflux disease.
Yes. Any other possibilities?
Could be
Stable
acute
angina.
gastritis.
No, this also can be considered.
Stable angina.
Yeah, possibility. In other consideration was musculoskeletal pain. Considering her chest pain, she's had burning type of chest pain without radiation and no autonomic symptoms. And she gives history of she's very obese and consumes a lot of bakery products, less fruit and vegetables consumption. And considering all those, our first DD taken as gastroesophageal reflux disease. And she had the same pain for more than 1 year. And she's obese and is on treatment for dyslipidemia. If you are considering those factors, we consider second DD as the angina. Then even though as she has presented with increased pain since morning, we have to exclude the possible acute causes of acute ischemic causes for the chest pain. Then for that we attend to with the investigations. But her chest pain is not, it's very, it's a burning pain, not a constricting type, and there's no radiation, no autonomic symptoms. And the pain lasts only for about 5 minutes. And no pain at rest. So the possibility of acute coronary syndrome, coronary event can exclude. And even then we have to confirm it with the troponin I and ECGE. Then regarding the musculoskeletal pain, she does not have pain on breathing or tenderness on examination, no chest tenderness on examination, so we can exclude the musculoskeletal pain. Shall we get on to the available investigations?
No, before that, Chulika, we were considering about pleuritic type of chest pain as well, because it may be the patient had some cough, I can remember, on and off. It's not that obvious cough. So because of that, we considered pleuritic type of chest pain also the possibility, but with the history, patient, the denied that the patient's chest pain was not increased with breathing, and as well as no shortness of breath associated cough also, so minimal disturbance. So because of that, we safely excluded the pleuritic type of chest pain, and she didn't have past medical history of any respiratory problems to have this chronic, the pulmonary diseases like tuberculosis or any other issues. So because of that, it also out, right? So those are the 4 possibilities that we have taken. Okay, now you can go ahead.
Thank you, madam. Available investigations, her TSH 6.8, fasting blood sugar 108, ALT 62, AST 63, total cholesterol 260, triglyceride 220, LDL 138, cholesterol to HDL 5.2, creatinine 0.6, ESR 19, rheumatoid negative. The cost-effective initial investigations we arranged at our primary care level, oxygen saturation 96% and 12-lead ECG repeated, and showed the same changes with the first ECG. High sensitive cardiac troponin arranged as from the outside, it was negative. This is her ECG. It showed complete right bundle branch block pattern with especially V1 with RSR pattern and inverted T, significantly wide QRS. It may be benign. It can also occur in right ventricular hypertrophy, pulmonary embolism, right heart failure, cardiomyopathy or ischemic heart disease or myocarditis. In the red flag pointers for acute chest pain is dizziness, syncope, pain in the arms, mainly left, jaw pain, thoracic back pain, sweating, palpitations, dyspnea, pain on inspiration, pallor, past history of ischemic heart disease, diabetes mellitus, and hypertension. Considering the available investigations and the history and examination findings, we arrive into the final diagnosis of final working diagnosis of gastroesophageal reflux disease. Because she had a burning type of pain without radiation, and there are predisposing factors like she's obese, and she consumes a lot of unhealthy foods like bakery products, oily and spicy foods, and possibility of acute coronary event excluded by the negative tropi, and the ECG does not show any progressive changes. Then at the primary, we decided to treat the patient at the primary care level, explaining the disease and the possible causative factors. And she has already taken several NSAIDs for the her joint pain. It also has contributed for the gastroesophageal reflux disease. And we educated about the possible causative factors and avoidance of them. We advise to her to avoid them, and assess about regarding the cardiovascular disease comorbidities. She already diagnosed hypothyroidism patient on less optimal dose of thyroxine. That also contributes to the elevation of her lipid level. So cardiovascular disease risk assessment we haven't done yet because as her cholesterol levels are already high due to the hypothyroidism, and we educated her about the need for the optimization of thyroxine and the proper compliance of the thyroxine. Then we arrange
The thyroid CVD risk assessment is compulsory for all other patients, but this particular patient, just to at some point to the Chulika's point, the patient is diagnosed patient with hypothyroidism, not on regular, the guided treatment, but she takes 50 microgram daily. But the patient is gaining weight, and her lipid profile shows that the higher LDL level above the guideline requirement, that is LDL 115 must be there or low, but it's high, 100 around 30s, and as well as cholesterol HDL ratio is more than 5, where the patient needs the treatment without assessing the cardiovascular risk in case of hypothyroidism with elevated cholesterol. We have to start the treatment, thinking twice. So because of that, CVD risk assessment is not essential for this patient. Right. Okay, Chulika, now we carry on from there onward.
Thank you, madam. Pharmacology management, we increased the thyroxine to 75 microgram per day, morning before meals as first thing in the day. And for the reflux, we started omeprazole 20 milligram per day for 8 weeks. That is also before meals after the thyroxine. And we gave mosapride 5 milligram 2 times a day, domperidone 10 milligrams 2 times per day, and we increased the atorvastatin to 20 milligram. And paracetamol 1 gram, SOS, and topical analgesic for her knee pain. In non-pharmacological management, we educated her about weight reduction and asked her to arrange weight monitoring monthly and dietary manipulation, avoid spicy food, oily food, bakery products, coffee and tea, and advised to include high-fiber cereals, fruits, vegetables, small meals on regular time. Do not skip meals. Leave at least 3 hours between evening meal and retiring. Main meal at midday, and arrange non-weight bearing exercises for her to conduct at home, raising the head of the bed to avoid the reflux when she is lying down. Safety netting and follow-up. We advise her to arrange urgent admission SOS if she develops severe constricting type of pain which lasts more than 5 minutes and associated with palpitations and faintings, and arrange cardiology referral for her cardiac assessment. We want to review with her with repeat ECG, full blood count, lipid profile, HbA1c and TSH in 3 months. Management of GORD. This picture I have taken from the Oxford Handbook of GP. There's a flow chart for a management of patient presenting with dyspepsia. At first, we have to see whether there is any
So according to the
evidence-
NICE guidelines, no? Right.
Yes, madam. There's any evidence of GI bleeding. If patient is having hematemesis, then it's a high risk. We have to admit the patient for urgent evaluation. If there's no bleeding, then we have to look for other possible red flags. Those are dysphagia, age more than 55 years, weight loss. Then we have to arrange urgent referral for endoscopy. If there's a past history of gastric surgery or any surgery, abdominal surgery, risk of gastric cancer, anxiety about cancer, then we have to consider routine referral. If there is no red flags, we can review the patient what he or she taking. Those are calcium antagonists, theophylline, SSRI, nitrate, bisphosphonate, corticosteroids, and NSAID. Concerning our patient, she was taking NSAIDs for her knee joint pain. If there's after reviewing the medication and lifestyle advice, if there is response, they can follow self-care. If there is no response, then we can treat the patient on clinical grounds at the primary care level with omeprazole 20 milligram per day. According to the NICE guideline, it is for 8 weeks. If there is no response for the omeprazole 20 milligram per day, then we can go ahead for test and treat for H. pylori. After treating for H. pylori, if there is no response, we can add on H2 receptor antagonist or prokinetics. If there is response, we can follow up the patients on symptom relief. Omeprazole is on as required basis for the symptom relief. If there is no response, we have to arrange the referral for endoscopy. Following endoscopy, if there is a reflux, omeprazole 20 milligram per day for 8 weeks should be continued. If there is esophagitis, we have to continue omeprazole 20 milligram BD for another 8 weeks. If there is poor response with omeprazole 20 milligram BD, we can add ranitidine or domperidone. If there is any,
How long you have to tell? How long?
That's also for madam 8 weeks.
Yeah.
And if there's
You have to duration as well, right? Okay.
Thank you, madam. Then if there's evidence of hiatus hernia, treatment is similar to gastroesophageal reflux disease management. There's evidence of Barrett's esophagus, omeprazole 40 milligram per day with plus or minus laser or plus or minus resection can be arranged after referral. Gastric ulcer treatment, omeprazole 20 mg BD with H2 receptor antagonist for 8 weeks with H. pylori treatment. Endoscope, if the endoscopy shows gastroesophageal reflux with strictures, it needs long-term omeprazole treatment, 20 mg BD. If symptoms resolve, we can continue the omeprazole low. If they are still persisting omeprazole symptoms, we can continue omeprazole lowest possible dose as required basis. Surgical management will be arranged with gastroesophageal reflux with poor quality of life. Options are fundoplication. Hazards of long-term high-dose proton pump inhibitors in elderly are bone fracture, vitamin B12 deficiency, magnesium iron deficiency, Clostridium difficile infection, community-acquired pneumonia. H. pylori treatment. Investigations possible at primary care level, serology assessment for antibodies and fecal antigen testing. The testing has to be arranged after 2 weeks free interval of proton pump inhibitors. Irradiation treatment clears 80 to 85% of H. pylori. There are two regimes. One is double dose proton pump inhibitors. That is omeprazole 20 mg PD plus amoxicillin 1 gram BD with clarithromycin 500 mg BD for 1 week. Other option, proton pump inhibitors, that is omeprazole 20 mg BD with metronidazole 400 mg BD and clarithromycin 250 mg BD for 1 week. Thank you. References: Oxford Handbook of GP, Malta's Textbook of GP, and NICE Guidelines on GORD.
So thank you, Chulika. So now it's over to you all to initiate the discussion. So let me know what are the difficult, any clarification you need to do. Before that, I will tell you, when you are assessing, because this purposely I asked Chulika to do this, because being primary care physicians, you must know how to assess the patient by using your best consultation practice. That is the establishment of the doctor-patient relationship through very good rapport building, as well as active listening to the patient, to find out the correct information from the patient, from the history, and for mainly focusing about the analysis of the symptom, duration, and then come to the possible tentative diagnosis, whether it's acute problem or chronic problem. And then accordingly, you have to go through the history taking, right, to identify any red flag symptoms, any the other psychosocial issues, right, or the contributing to this factor, this problem, or there are family issues. So that is the importance of taking history, even though it's GORD or any other the complaint, right? That is the rationale. So having done that, this particularly GORD management, now I'm aware that we all are mostly doing the wrong management for the patients. That is not the correct thing. Each and every tablet, the will. So once we take it into the body, that will give you a lot of adverse effects, and as well as drug interactions, which delay the other drugs, the giving the effects to the system, the diseases. So you have to be very much careful whenever you are prescribing a tablet or capsule. It should be ideally according to the guidelines, because guidelines have been published after doing so many researchers, meta-analysis, random control trials, and Lot of researchers, not just like our Ayurveda, just putting them without having any researchers. So because of that, it's very important for you all to know the guideline management after this training, right? So while doing your training, if you apply these things, you will be, become a competent, the clinician, primary care clinician, and as well as your exam, getting through the exam will be very much, the easy and convenient. You're at the end of the training. So those are the two focuses. So particularly regarding that GORD management, because this could be, as you all mentioned, as differential diagnosis, GORD, that is gastroesophageal reflux disease, that may be the acute gastric erosions, right, gastric irritations, or that may be due to gastric ulcer, or that may be due to gastric cancer, or esophagitis. So those are the possible diagnosis underlying for this particular complaint. That is, the burning chest pain, right, which associate with, we have to differentiate with some few, the symptoms. So this patient is having getting on and off this thing progressively for last few months, because she has started the taking, the NSAIDs, and patient is getting, the putting on weight, and patient was eating, without consideration any, the dietary control. The more the towards the bakery products, like pastries, rolls, buns, and all, for last few months, because now our people are getting shifted from their normal day-to-day cooking, the culture to the bakery products, because of the availability as well as the financial situation. So this patient also same, and with the weight gain, the patient has, got a knee joint pain. So getting worse, that is somewhat OA. She was diagnosed as, and for that she was taking, from incompetent, the general practitioner close by, and on and off whenever she goes there, they have prescribed just the NSAIDs. Please don't do that without assessing the patient properly. So this patient has been, given that NSAIDs also previously frequently, and she has gone over the counter medication as NSAIDs also she has concerned. So because of that, the patient got this gastric, the symptoms, but we diagnosed as GORD because on lying down, the patients, the symptoms are getting worse, and sometimes the cough also, on and off cough, right, the patient got. So it not just the gastric irritation, so the reflux disease, that's why it's referred as chest pain as well. Okay, otherwise mainly the patients are coming with, dyspeptic symptoms, the bloating of the tummy, and sometimes the discomfort of the upper abdomen, but no, the burning sensation while lying down. So we came to the clinical diagnosis. Most tentative possible differential diagnosis was GORD at the end of the history taking, and confirmed by epigastric tenderness, right? So then disease is correct. The DAVA diagnosis is correct. Now, according to the guidelines, for we are used commonly. So how much I just want to initiate, the discussion from you all. How does you all treat for the omeprazole with these patients? Yeah, come on, you talk.
In the dosage,
Yeah, just how, if such a patient comes, how do you treat? You just let me know, because you can make mistakes and we are there to get that corrected, right?
madam, usually we use 20 milligram 2 times daily for 8 weeks, madam.
Of course, that is the thing. So even we also doing sometimes the wrong management. Most of all, you all will do, I hope, right? So that is not the correct dose mentioned in the guidelines. Once you detect this, for GORD, gastric irritation, right? So we can go ahead for, the 20 milligram daily is the recommended dose, right? That's also before meals, not soon after meals. So that will, that will protect the mucosal barrier by preventing the acid, the production. So that is how it acts. But, the Chulika mentioned about the side effects of the drug, the proton pump, PPI. So there are so many bone fractures and, sometimes so many things she mentioned. What are those, Chulika, side effects?
Osteoporosis.
Osteoporosis. What else? Several things she mentioned. Those are the
Deficiency
learning
of
points.
vitamin B12,
Vitamin,
iron and magnesium deficiency, Clostridium difficile infection, and community
Clostridium difficile infection. Yeah.
community predisposition to Clostridium difficile infection and community acquired pneumonia.
Community acquired pneumonia also, right? So because of that, we must know the side effects, because acidity, some sort of acidity is needed to prevent those. So because of that, when we prescribe a drug, we have to know the guidelines. So here, so it's 20 milligram daily dose, the morning or evening, depending on the patient's symptoms, mostly morning, I think. So before meals, you have to advise the patient to take, right? And the prokinetics can be added according to the symptoms, like domperidone and as well as the mosapride, like drugs twice daily. So once you identify such patients, that you can initiate the treatment on symptomatic and confirm the clinical diagnosis. But, only for the 6 to 8 weeks, the guideline says, at a stretch, while, removing the positive factor for the patient. Here the NSAIDs and as well as the weight gain and the dietary factors like bakery products. We have to strictly advise, we must convince the patient these are the factors that have been, created your problem. Then you have to be away from that. Otherwise, no point of just giving the tablet. That also very important. That is the patient-centered management. So on another patient, this may be the cause, maybe not the NSAIDs, it's the bakery products, right? Or another patient weight gain. So like that, you are having, sometimes other drugs like nifedipine, something else. So that is what we are telling, patient-centeredness. You have to identify what the underlying cause is. Okay, that is very important. Then you have to remove that cause as well. Okay, now she told only the once daily dose according to the guideline. But if patient is not responding, the patient response is very good, and if she is getting again after some time, per required doses can be given, right? But again, we can, ask the patient to go ahead for another 2 weeks timeline. But still the patient is coming with, the same history and these things, while removing those factors, then you have to think about sending the patient for the endoscopy. That, the indications she correctly mentions, age 55 years or more, the weight reduction at very first time, we have to send the patient without thinking twice to the endoscopy. Or the normal patient, the after no response, we can send. So you have to know clearly who are the patients that we have to send for the endoscopic referral. That is at very first, weight reduction, weight loss, then age 55 years at even very first time we have to send, right? And as well as, there are the hematemesis or melena, right? Positive history. Those are the important, the things that we need to, send them without any delay, because our agenda is to find out any underlying gastric ulcer or any underlying malignancy in the carcinoma, right? Carcinoma in the stomach or any esophageal, erosions. Those are the very important agenda behind whether once we get such a patient to exclude such, the serious pathology underlying. So that is how we are thinking whether we can treat or we need to send this patient to the other, the gastroenterologist. So that is the rationale behind. So she told me, she mentioned again, in case of esophagitis and the Barrett syndrome, then we have to gastric ulcer. We have to straight away we can go for the 20 milligram, the twice daily dose, right? And for some conditions like Barrett, we can increase the PPI dose to 40 milligram, the daily dose. So there are indications for you all to go for the twice daily doses as well as the double the PPI dose. That is, we used to call full dose of PPI. Usually, other than that, we used to start the treatment with lower dose. Lower dose is 20 milligram. So lower dose of PPI is 20, full dose of PPI is 40. So that you have to know, right? So that is the very important thing behind this patient management for you all to get that particular knowledge. Identify the causative factors, remove those, and then go with PPI and the prokinetic management. Then identify the patients who need the lower dose of PPI, and who are the patients who need the full dose of PPI, and then who are the patients who need the lower dose twice daily. So those are the very much, the very good indications that you have to be clear about when you are going to manage the patient. So if you are doing such way, the patient will not be mismanaged. Patient's diagnosis will be correctly managed so that the patient will be getting the recovery according to the safe patient care. Other than that, this particular patient, the hypothyroidism, and I always want to give you this message, even though this is, we will discuss another patient with angina in order to discuss guideline management of angina. But here, this patient is since hypothyroidism, not, the checked her the thyroid functions and dyslipidemia regularly. Fortunately, she came with reports where we have, detected that her the thyroid function has not been, under control, because she is gaining weight, she has constipation, and her positive on examination, her BMI is 36 and the ankle jerk is delayed. So with that, we could, able to diagnose her clinically hypothyroid patient, which is not adequate for her thyroxine treatment on those symptoms and the positive signs. Even though thyroid gland is not enlarged, the pulse also more towards the hypothyroid because 64 and low volume pulse. And the other positive sign is ankle jerk, right? So delayed ankle jerk need to be tested for each and every patient who you are suspecting, the hypothyroid. So please keep that in mind. Other than that, any other, the positive, the signs may not be there, but ankle jerk may be delayed or the pulse volume may be very much low, like that. So you have to put your attention to the patient. So this patient, not only the coming with the single problem, the patient is having that on top of her weight gain due to the hypothyroid, uncontrolled hypothyroid status, and her dietary factors has given her GORD as well. So we need to treat the patient as whole, not as the disease. So because of that, we are considering these three issues for patient to recover out of that. So because that is called holistic care in general practice. So always you identify the problem. So the correction of thyroxine amount we have done to 50 to 75. And because her weight gain, she's at a higher risk of stable angina, unstable angina, or the CVD event. The other one nicely, the excellently, told that differential diagnosis may be angina. That is really correct. So we have to, that is opportunistic health promotion that we are going to do for our patient. That also one of the preventive care is one of the family medicine, the role in the family physician. So this is the first contact care we have done, and we have the coordinated the patient with cardiologist to do the ECG and as well as the 2D echo in next visit, and we have the provided opportunistic health promotion by asking patient to reduce the weight, increase the thyroxine level to 50 to 75, and then we send the patient for to detect the cardiology referral in order to go ahead with ideally the echocardiogram. Not only that, the stress and the exercise testing as well. So these are the important the functions of a family physician whenever you are get such a patient at first contact care. So those are the mention in your books as the principles of family medicine or roles of family physician. So you can discuss in your paper, they comes as this, right? They describe this given this case scenario, describe the types of the principles that you have been practiced on this patient. Then you have to say for telling the small thing advances, but the safe the best patient evidence-based patient contact care for the GORD by giving this. And then you have to tell the coordinated care by referring to the cardiologist. And opportunistic health promotion you have done this by encouraging patient to that and this like that. So that is how you have to manage your patient. So the very much safe patient management we have done. We ask the patient to come in another 1 month's time. And correctly, she mentioned safety netting is very important part in your management. So patient was asked to come to the hospital without any delay. If she gets any chest pain, we don't know because her lipids levels are not good, right? And she is non-hypothyroid patient, and we don't know the next time she may come with the angina, so or coronary artery disease. So because of that, we told now, but we safely excluded it's not MI or angina by doing ECG, right? Because MI in case of the troponin should be positive, but in case of stable angina or unstable angina, troponin is negative. So, but ECG will show you the signs, give you the disease, the plus patient's history. So because of that, we have safely excluded that, but we don't know the time when will be the next time that she's going to meet up with these much of the high risk factors. So we safety netted the patient. And out of all, the important thing that she has done the good counseling to the patient, saying that it's likely, it's the disease called GORD in medical terms, but that is your acid is coming from the stomach to the tummy to the food pipe, which can give you the irritation which causes the chest pain. So, but the reasons that we have found is your on and off, the painkillers that you are getting for your joint pains as well as your weight gain and the bakery product. So because of that, I will advise to be away, how to be away from those, and exercise, not the walking. Advice for this patient to reduce the weight. The non-weight bearing exercise can be done because it's really helping to reduce the weight as well as to improve the system. So because of that, even quadriceps tightening exercises and as well as the normal, the yoga and all really helping. So because of that, some patients will listen, but your duty is to tell the patient, and the weight monitoring is very important motivation for patient to come with the next visit to check the weight. Then the patients are, the nicely, the listening to the advices that we are going to give, because they know that next time we are going to check it. So those are the important points in our management. So now you take this opportunity for you all to, discuss this problem to clarify some more, the doubts if you're having. Please come out and we are there to help you, right? Okay, this is a discussion. So not to assess anyone's knowledge and not to assess anyone's competency, nothing, right? This is to assess the weakness, how much we can help you all to get ready for your evidence-based practice and as well as to the exam and for the motivation for the exam as well. So please come on.
Madam, I'm Dr. Keith. Shall I add a few words about this management?
Yeah.
Yeah, actually, this the dose actually given this the guidelines usually as the uh, one of the students spoke that we used to give the BD dose, but this is the guideline says rather the naive symptoms, the complicating one. So there's obvious cause that there's a NSAIDs injection chronically, and in such case,
Can't hear,
this
Kirti.
yeah. In such case, these red flags are all out. All are the 9 things, and there's, I think, less symptoms. According to the guidelines, say that if there's any suspicion or any severity suspicion, any suspicion of esophagitis, difficulty in swallowing, and all that, we have to refer. We have to refer for endoscopy, which is not we are not doing because of the various things. So in ideal practice, we have to refer. So these are naive because we can't see the esophagitis. It may be acute gastric ulcer. It may be probably high malignancy because the disproportionate symptoms we have to refer according to these guidelines.
Of course, yeah.
So we actually overtreat sometimes. We are overtreating for the esophagitis and gastric ulcer, gastric erosion, even without thinking that sending the patient.
Yeah, correct.
So
That's a very valid point that you have raised. That is not according to, or even though the guideline mentioned that the age and the symptoms of the esophagitis, right? And the symptoms of gastric ulcer is more severe, right? It's continuous pain, not like the pain. The pain will not be lasting less than 5 minutes. Here in our case, it's the patient gets pain, usually on and off pain, because but 5 minutes it stays, right? So it's not more than that. We analyzed it correctly. So then like that you can diagnose your patient correctly. If your knows the how much severity it is, patient perception is very important. That is the consultation skills which we need to practice. That is the active listening to the patient. Patient will say, doctor මේක නම්මට දරන්න බෑ කොහොමවත්, right? Then you have to grade the severity 0 to 10, how much it is, right? Even though patient is not showing by the face that the verbal, not only the verbal, non-verbal cues also important, because patient may be in pain and patient will not ask you to touch the abdomen. That much of a severe tenderness may be there. But other than that, patient says, doctor, මේක මට දරන්න බෑ මේක ඇක්කුම ආවහම, right? Then you have to ask how long it will there stays, and as well as what is the severity at that time, right? So in such a case, you have to think definitely that it's not just another GORT, right? It may be the acute ulcer or the severe gastric erosions, which may be sometimes even without the melena or hematemesis, the patient may be having. But that is why active listening helps in. That is why we are training you all to identify the patient from verbal as well as non-verbal cues and actively listen to the patient. Use your knowledge, get the cross sections. Because if you think that this may be the more serious situation, right? Even though patient comes and says chest pain, I had that at that time, it's severe, you have to assess the severity. Of course, at that time you should not keep the patient at home. I know there is a minister, the ministers, one of the very really they are maybe known to us, and her wife his wife was telling me, I am getting severe pain of, not severe, this pain is really bad, it's coming and, it stays there, I can't even, no appetite at all. Then when I asked what type of pain, it's from coming me papu madin tamai enne. Hari, and she told me that, it's නිකන් පිච්චෙනවා වගේ එනවා. හරි. හැබැයි ඊට වැඩිය මට මුකුත්ම කන්න බෑ. කටට දාන්න බෑ. Right? දැම්ම ගමන් නිකන් vomitish feeling එකක් එනවා. It's regurgitation වගේ එනවා like that. So when I asked any, she never had, because I know her, never had any, the symptoms of gastritis in her past, right? She didn't have any other, the positive factors like that we were discussing. Okay. But ultimately, I was asking from her, any, the tablets did you start taking, right? Then then she was telling a week back, she had a fall. Okay. And ඊට පස්සේ මෙහෙම outstretch hand එකේ වැටිලා මෙතන අත ඉදිමිලා තිබිලා තියෙනවා wrist එක. So she has, whenever a doctor known to them used to come, usually he visits their house. එයා ආවහම එයාගෙන් අහලා තියෙනවා මේ අත ඉදිමුනහම මොකද මෙතන ඉදිමිලා වැටිලා මොකද කියලා. So he has to check for the fractures එච්චර තිබිලා නෑ මොන හරි එහෙම x-ray එකක් අරගෙනත් බලලත් ඒකත් that is normal කියලා swelling තිබ්බ නිසා ultimately he has given her bisphosphonate, right, weekly ganda kila. So 2 days back she has taken without any advice, he has given that capsule. Eka mama දැක්කේ මොන අත කැඩුන හින්දා අත මේ වැටුන නිසා අත ඉදිමුන නිසා මට ඔන්න ඔය අහවල් ડોක්ටර් බෙහෙත් ටිකක් දුන්න බලන්න ඕකේ කියලා කිව්වා. හරිද? When I checked, it was the bisphosphonate. Severe gastric erosions, right? She couldn't eat, she can't this thing. මාර අමාරුයි. මොනවත් කරන්න බෑ. ඉතින් එතකොට then only I realized that this fellow has given these capsules that has been caused this, the gastric erosion. So what I did was, so she was really refusing to go to the hospital as well. බෑ. She මොන හරි කරන්න මට දැන් යන්න බෑ. ඉතින් ඊට පස්සේ බැලුවම pulse BP හොඳයි. So I started her, the IV PPI. IV PPI දවස් 3ක් දුන්නා daily. මේ dose එකක්. Daily dose for 3 days. ඊට පස්සේ oral මේවට දුන්නා PPI. මම ඇත්තටම full dose එකක් දුන්නේ. හරි? full dose එකක් about, I think 6 weeks, 8 weeks කිව්වට හිම අරන් තිබුණේ 2 weeks අරගත්තාම ඔක්කොම හොඳ වුණා කිව්වා. හරිද? That has been caused by that bisphosphonate. You see? So if you have to කීයටවත් කවුරුත් එක්ක මොකද stomach area එක අත තිබ්බාම කිසිම tenderness එකක් නැහැ. Epigastric tenderness එකක් නැහැ. That is the lesson I learned. So only she complains. මෙහෙම ඇල්ලුවාම මෙහෙම රිදෙනවා කියන්නේත් නැහැ. That is the severe gastric erosion. She couldn't eat. කන්නම බැරුව තිබුණා. So ඊට පස්සේ හිමින් liquids ටික දීලා තමයි මේව කරගත්තේ. So better not to the practice, the unsafe medicine. So that is what our country, because they haven't got training. තව පොඩ්ඩෙන් අරක මේ මනුස්සයා ලොකු අමාරුවක වැටෙනවා. So that is the important thing. The Kirti's point is very valid. Depending on the patient's severity and the symptom, you have to think of whether this patient needs the urgent, admission for PPI IV දෙන එක ගොඩාක් important. ගොඩාක් ලොකු මේවා එකක් ඇත්තටම in case of that, because I'm seeing more tour patients, involved patients as well. Lot of patients are being recovered with severe gastritis. Alcohol හිම අරගෙන ආපුවාට severe gastritis. They can't eat, drink. So because of that, you need to refer such patients, because if your clinic doesn't have such facilities, you need to send the patient to the GORD, the specialist, right? So gastroenterologist. So they will manage the patient according to their specific specialized knowledge. But you have to know why you are sending this patient to the gastroenterologist. That is a very important thing. Thank you, Kirti, for that valid point. Anything else? These are the discussion points, you know.
Thank you very much, madam, for the kind explanation regarding my presentation.
Yeah. So what else? Any other questions? ඔක්කොම නිදා ගන්න ගිහිල්ලා 29ටද කොහෙද බහැලා 40ට පොයි.
Madam, what is the place of antacid in this case?
Yeah.
GORD.
Yeah, antacids, you know, have a very good place in GORD because if the patient, you know, when we are assessing the patient, when we give the treatment, you know, if the provided that the patient is okay, right, recovered after full course of treatment with the low dose of PPI, then the patient like this, you know, the obese patient, again, till the weight get proper control, her GORD symptoms will persist on and off. In such a case, we told, according to the guideline, they can start, you know, per required doses of PPI, as well as you can add, you know, the antacids, right? That will really be effective. And the guideline also mentioned, other than the prokinetics, you know, you can PPI, prokinetics, and antacids, particularly H2 receptor blockers as well, right? H2 receptor blockers will work to, you know, neutralize the already secreted acid inside the stomach and the esophagus, right? So because of that, it's really good for you to start, you know, the ranitidine or famotidine, right? And they say, the guidelines say ranitidine. And as well as, you know, the antacids also doing same thing. It will, you know, the neutralize that already formed acids, right? So because you just check below that, I'm not, you know, the really fully updated about antacid. So, but you have to check on that as well.
Thank you, madam.
Okay. So what else? Out of all, weight reduction is the number one therapy for GORD. Because for the long-term sustainable recovery. And if
Guidelines
it
for the antacids also give the quick response because it quickly neutralizes the
yeah,
acidness.
that is the thing. That is
It's a
what I told.
quick relief.
Yeah, quick relief, already neutralized acids will be, you know, the neutralized, already secreted acids will be neutralized by antacids and the H2 receptor blockers.
Are there any role in combining proton pump inhibitor with H2 receptor blocker?
Yeah, that is what we were talking. But not at the very beginning. Guideline says at the beginning, right? Minimum, you know, the guideline always, you know, the carefully introduce the capsules or drugs to the patient's body, right? So that is, you have to keep that in mind. Although so many, the tablets available, better not to. That is the importance of, you know, the being stick to the guideline management. Always respect to the patient's life and go ahead, because guidelines are guidelines. They have, you know, the checked it. They have, you know, the piloted on patients. They have done researchers, many. So they say initially the low dose PPI, that is 20 milligram daily dose. That is more than enough. So please, from today onwards, you start your practice by giving that, right? Otherwise, we don't know when will be the patient ended up with, you know, the difficile, the diarrhea, right? Clostridium difficile. It's really nasty. The patient life might, you know, be the end, right, of that if the patient gets that. And as well as, you know, the osteoporosis long term with the high doses. So better not to. So use always, being the family medicine registrars or the primary care, the doctors, if they have joined from the capacity building, please, you know, try to be a decent doctor, but the guideline says this helpful, definitely it will help. But you have to tell the patient, this is the correct management that I have done. This is the problem that you have now. So because of that, this is the treatment. But in case that if it's not recurring, please come to me after the 8 weeks or in between time. That is safety net. And then patient knows, right? Patient will not leave you for some other doctor. But if you are not talking to the patient about his or her problem, not counseling properly about the problem, patient will go away. So without counseling, giving lot of the medication, even the 101 medication with the gastritis, gastric irritations is not the correct method. So you have to tell the patient, this is what I am doing because of this. This is the guideline that it will give you some relief, but some people not. So in such a case, you please come, because instead of the tablet, patient has to do a lot of things, they reduce the bakery product and not to take over the counter medication for the joints, right? Instead, you can give you the paracetamol, local massage and local application like that, and the weight reduction important. It's an opportunistic health prevention. Once the patient got some issue due to the weight gain, you have to tell, this is because of your fault. So because of that, I'm there to help you to reduce the weight. So please come with this much of advices. I'm going to help give you. You can refer to the nutritionist. Okay. What else? Another thing is, so when we are prescribing NSAIDs, right, and prednisolone or something, we are going to anticipate the possible, the gastric irritation, and we are going to give them, the PPI, right? So in such a case, I think, right, for patients, it's whenever the drug, the nasty drug is going into the stomach, right? That will, put the patient at risk of getting gastric irritation. So such a time, we have to cover her, telling, the best possible precautions to take the soon after meals, and concomitantly, if the patient is such a patient who is more the prone to get, or the patient is at a higher risk of, the risky patient to get the gastric irritations or ulcers, then you have to prescribe the PPIs concomitantly. So I think that is safer management, but only for the short duration.
And madam, if a patient is having high risk of GORD, we can give the NSAIDs with less gastric irritation, like meloxicam, COX-2 inhibitors.
Yeah, COX-2 inhibitors, but still, even though they say less, but some patients gets it, right? But it's the best option is to go for that. Yeah, correct. But in case of ulcers, right, Barrett's esophagus and phagus and esophagitis, recent past history of those things are there, right? So better not to give any, the sort of, even though it's indicated. So in such a case, you can give them, the short courses of tramadol instead of, and the potentiate the pain relief with paracetamol, and as well as some other local reliefs and all. But if it's really indicated, you have to get some opinion from the relevant specialist in the pain management as well. I think we always have to provide the better, safe patient care. So instead of relieving this, if we are giving, instead that patient is non-patient with the past, the gastric ulcer, gastric pathology, where we have to be very much cautious. So in such a case, to do that.
Madam, regarding the on-demand dose of proton pump inhibitors, it is After dose of regular dose, that is on-demand dose is 10 milligram, according to the guideline.
Ah, is that so? 10 milligram PPI?
Yes, madam.
It's not 20.
Off-label dose, on-demand dose.
But we don't have 10 milligram. In our country, we don't have no 10 milligram PPI.
Yes, madam.
So there are also no point of talking, but for your knowledge, for the MCQs, you have to know that. Other than that, for practicing, we have to go for 20.
Thank you very much for all the participants who attended, and thank you very much, madam, for your kind guidance and the nice discussion you arranged at the end of the presentation.
Okay. So no any other questions? Then shall we wind up?
Thank you, madam.
Thank you and good night.
Okay. Right. Okay. Good night.